All right. So Mr. Jones, in terms of getting your excellent history, he tells you that he was diagnosed with HIV 3 years ago. He states that his viral load is undetectable. He believes his CD4 count was, quote, pretty good at last check approximately 6 months ago. He is without any other medical issues other than occasional seasonal allergies. He states that his parents are in good health. He reports occasional alcohol use, smokes cannabis daily, and denies other substance use. He is sexually active with 2 male partners and engages in receptive and penetrative anal and oral sex, endorsing routine barrier protection. He reports a prior history of chlamydia infection about 9 months ago, and then again 2 years prior to that. Works as a graphic designer currently and lives alone. We'll get into some of the social history and some of the management stuff, but I did want to give a space to at least talk about your initial physical examination, if this diagnosis changes anything that you would do, or if it's just sort of your routine bread and butter.
Sure. I think a lot of it's visualization, actually just like looking at the patient. If they seem anxious, overall, that gives me some kind of things to kind of look for. Also, the things I'm looking for during my history, and even though it's part of the physical, I always do like a full review of symptoms because it might kind of gears me if there's issues with adherence. Things I'm looking for really is if there's been any weight loss, any night sweats, any fevers, have they noticed any lymphadenopathy overall, because it might gear to me on what I'm going to focus on my necessarily exam as well. And then thinking about the sexual history, actually, which I'll talk about in a little bit, but I think one of the big things is if they're having any active symptoms, because again, one of the big things I try to do on the exam is make sure that, we're not missing anything on the diagnosis. And then for the physical exam, really just like I tell the residents, it's really just head to toe. But, a couple things for me to kind of keep an eye on is if there's weight loss, if the patient looks cachectic. I think other things, if there's visual field deficits, the rooms have ophthalmoscopes. We can use them for reminding them that they're there, other than paperweights. I do a good full skin exam, lymphadenopathy, and then depending on patient preference and reading the room, unless there's an active symptom that's concerning for me for an STD, I also make sure that I try to do a sexual health exam as well, but that might also be determined by patient comfort.
And you mentioned looking for cachexia and everything, but one thing that I was not as aware of, like people with screening for metabolic syndrome or just like weight gain on medications. Yeah. Can you speak to that a little bit? That wasn't really on my radar.
Totally. So like also part of my exam is looking through the vitals and then also looking for like anything that's suggestive of metabolic syndrome. So why is that? Because I think, patients had mentioned that there has been weight gain with certain HIV medications. And I think a lot of times back in my day as a trainee and as a student and as a fellow, we used to always mention that, HIV is this catabolic state. You're undetectable, you lose fat deposits, you're on medications. That's why you're gaining weight. Although, since there's been newer treatment options, which is awesome in the sense that they're easier to take, has less reportable side effects, they suppress the virus really well, we're learning a lot about our patients on these new medications. And I think there's been a lot of association with weight gain as well. And when we look at that, it's also not necessarily equal, actually. So I remember reading something where about 1 in 6 patients within the next 2 years will gain 10% of their body weight, actually starting on antiretrovirals. And when you split that even more, the weight gain's even higher in African Americans, and especially African American women. So nearly 20% of patients. And some of these studies, I think the one I remember is like the Advance trial, noticed that there was about a weight gain about up to 6.4 kilos. So, is it part of the medications? It could be. I think some of the newer formulations, when we used to use a lot of tenofovir disoproxil. We kind of advanced to tenofovir alafenamide. We're noticing that there is some weight gain, and there might be even more concurrent weight gain with some of the integrase inhibitors. So when we're thinking of dolutegravir or bictegravir. So it's something to kind of think of console. So as exam-wise, it's important to note to keep an eye on that because there is going to be some weight gain. And I think preparing patients for that, if you want to talk about adherence, is important.
What do you do in terms of mitigation strategies for that? I mean, I know this is not the episode for initiation of therapy, but I guess if you were at that point, like, is it just anticipatory guidance? How do you talk to that with patients?
I think I've changed my focus on a couple things. I think one, I really think about talking about like diet and nutrition very early on. And then again, it's really not just that. It's really checking if there's access to healthy food. So like, I think if there's an issue with that with patients, I might tie that in with my case manager or local resources to kind of focus on that. I think 3, try to really form and talk about physical activity. When I talk about physical activity, that's another kind of sneaky way I kind of find out safety of the neighborhood, because like there are some neighborhoods where it's not super safe to go exercise outside. It also has made me rethink sometimes med switches. So a lot of times, the thought process is a newer medication comes out, super great, less side effects, but if my patient haven't had issues to change them, sometimes it's conversations now that I initiate. Hey, there's this newer option, but let's sit down if this is the right option for you. So I've been rethinking some of the initiations and switches overall. Or if I do switch, mentioning that this may be something that we will note, actually.
For the patients that I've had some patients recently tell me that they started doing YouTube workouts because Peloton, all those things are expensive, unattainable for a lot of patients, but there's free workouts on YouTube and things. And same thing, patients are my neighborhood's too dangerous, so I don't walk around. Or during the pandemic, people weren't comfortable going outside, so now they're doing that. I did want to ask you, switch. Is it okay to talk about labs now, Paul? Are we moving into the initial labs, or we have something else? I can save my question.
Well, I guess while we're here in sort of metabolic land, I guess, are any other considerations? I know that I hear some rumblings about sort of screening and diagnosing diabetes and sort of choosing labs for that and timing of the initiation of ART and that kind of stuff. Is there anything that might be a little bit more nuanced than we need here? But from a primary care standpoint, is there anything that we should know about specifically between HIV, its treatments, and diabetes?
Yeah, I think as part of the one thing that's really interesting, and I'm happy to have patients that are living longer lives. I'm happy for the day they're cured and I lose my job. I tell them I'll cry tears of joy with that. But there is a risk for cardiovascular disease about 2 times higher in patients living with HIV, even being undetectable, and higher CD4 counts. So I think as we look back at that, there's some kind of big focus points for metabolic syndrome. I think one of the things is really being aggressive to screen for diabetes. I think also making sure that lipid profiles, that we're not just checking them, we're actually treating them, actually. So as we're thinking about things, I have many patients who are super well controlled for the HIV. Their diabetes needs a little bit of help, actually. And I think one of the big things as I focus on that is highlighting that that's probably just as important or even more important for mortality overall than necessarily just treating your HIV. So I think I tend to do a lot more screening. And then as I'm thinking about my antiretrovirals, as we talk about switches, it's important to think of what medication interactions there might be. I think one of the big things is making sure that if a patient needs to be on a statin medication, to really think about that. And you can't just go by the ACCVD risk factor in our patients for living with HIV, because we're not actually part of the calculation. We know there's a risk. So as I discuss with my patients why I'm doing stuff. And I think one of the big things for my patients is I feel a lot of times overall, both non-HIV, more meds. I'm always pushing meds, right? They want less meds. But I try to really focus that, hey, if you have a heart attack, there's going to be about 3 or 4 meds I'm going to add on to your med list that probably won't go off.
Yeah.
And I think that's if you have a minor heart attack with no dysfunction after. And then for us, for mostly taking off the patients for boosters for cholesterol medications if we can. Some of the protease inhibitors can cause dyslipidemia. The newer ones, not as much, but compared to the integrase inhibitors, they tend to be pretty lipid neutral. Mm-hmm. But my dosing for the statins can be contraindication. I have to start with a lower dose and make sure that they're not having any side effects. And the statins we tend to use is rosuvastatin or atorvastatin overall. For diabetes management, some of the longer-acting integrase inhibitors actually do interact with metformin, so the dosing should probably be a little bit lower. So thinking about dolutegravir and bictegravir. But I think one of the big things is just making sure that as a provider, we're doing just as updated care for HIV for their primary care. So if they really are indicated to get a GLP-1 for diabetes, really thinking about that. If they need the statin, really thinking about that overall. So I tend to be pretty aggressive on that. And same thing for blood pressure control.
Do you have any preferred resources for the statin interactions, or do you just know these off the top of your head at this point?
I always double check.
Great, thank you.
I think I always double check. There's a couple great resources. I think University of Washington has this self-study module for HIV and also HIV in primary care. It's free. It's amazing. They also have one for Hep C. UCSF also has one where I think they're just revamping the website because it's been off for about a year, and it's called the Knowledge Link. And it's great because it's all topics necessarily all towards there. Those are my kind of go-to ones. And then I know I'm digressing a little bit, but I think as I talk about my patients is really focus on smoking, because there's a much higher prevalence of smoking in patients living with HIV. And I describe it as, a couple years ago, our journal, Clinical Infectious Disease, had an article on smoking and smoking conversations to have with patients, reviewing their treatments for patients, pretty much a primary care article in a infectious disease journal. And I think it just shows that the prevalence of smoking is much, much higher.